You're listening to Estrogen Dropouts.
Welcome back to Estrogen Dropouts. I'm one of your hosts, Elizabeth.
And I'm your other host, Erin. And today we have a special guest with us, Nikki Sapiro-Vinckier. She is an OB-GYN physician assistant, author, and reproductive health educator. She is the founder of Take Back Trust, a platform that helps people navigate reproductive health care with practical tools and clear information. Nikki also creates educational content for an audience of nearly 200,000 followers, breaking down complex medical and political issues around reproductive health in ways people can actually understand. She is the author of the upcoming book, We Deserve More: How the Medical System Fails Gynecological Health Care and What You Can Do About It. So we are super excited to have you. Most of our listeners, Nikki, are women that are perimenopause, menopausal, postmenopausal. Elizabeth and I both fall within that range. And so I think a lot of listeners that follow us definitely can relate to all of the issues that, we're going to speak about today. I wanted to ask a question right out of the gate. What do you think is the biggest misconception you hear about perimenopause and menopause in your clinical practice?
I would say that a lot of people assume that menopause is kind of all of the pieces that they're experiencing, and that's actually perimenopause. So perimenopause is the window of time that leads into menopause, but by definition, menopause is really just a single day. And so menopause, by definition, is the absence of a period for a full year. So once you hit that benchmark of 1 year without periods, that's when you're postmenopausal. So menopause in and of itself is really just kind of 12 months while you're counting and ticking those time bombs of no periods. Anytime you have a period, if it's irregular, then the clock starts over from there. But I would say it's really perimenopause that we're all talking about now more so. Is it true that menopause automatically causes severe weight gain and loss of libido? Or what are your thoughts on that? I feel like those are the two biggest ones that we hear the most, is that people are like, I've gained weight in the middle. I know I've been on a GLP-1 and I've lost some weight from it, but I cannot lose, like, my midsection is wider when I used to be like more spelt there. And it's just like, I'll lose weight other places, but there I cannot. I don't know what's going on. And then the libido is tanked. Yeah, so there's so many pieces to that puzzle. Would I say it automatically causes that? Absolutely not, right? There are some really lucky individuals that slide through perimenopause and menopause without a single issue. And those are the super lucky ones. And I'm always like, shh, don't tell your friends, right? But it's definitely not a guarantee that you're going to see anything. And just like any other medical change, people experience different things. So some women have more hot flashes than other women. Some women notice more weight gain than other women. Some women do have libido changes more so than other women. So there's definitely kind of this spectrum that people notice. And so nothing is a guarantee. Nothing is a death sentence, right? It's all kind of this continuum, if you will. It can be very common to gain weight, and a lot of that is perimenopausal related. A lot of that is, as we age in general, our metabolism just really slows down. And so that ends up coinciding at the same time as perimenopause and menopause. And so we see them related very often, right? In terms of libido changes, there's a lot of things that play into that. One of the biggest issues we see specifically with perimenopause, though, is vaginal dryness. And I'm sure we'll talk kind of more about estrogen use at a later time, but that's one of the things that can really help with that vaginal dryness. And the more irritated we feel vaginally, the less comfortable it is to have intercourse. And the less comfortable it is to have intercourse, then it's pretty natural that that libido goes down too. Libido in and of itself, there's a lot of pieces that play into that equation. It's not like a one perfect answer is going to solve it. But I definitely think there's so many parts of perimenopause that are related to the libido piece too. Well, do you think that the estrogen, just the vaginal estrogen, is a big difference between, and because whatever you take, Erin, then I started taking that, and then I kind of stopped with the estrogen vaginal. What do you take? You want to tell what you're doing, Erin?
Yeah. So I had breast cancer in 2014. No doctor, no PA. will prescribe estrogen or progesterone. And it's interesting because I just called my medical oncologist today because I see her still every year, just mainly because I love her. um, we just check in once a year. And she was saying, so much with the black box warning being taken off of all of the hormones for women that have had, breast cancer. But my doctor still will not prescribe. And I see actually a PA in that practice will not prescribe estrogen and progesterone. And she's like, you had stage 0 DCIS. There's no reason why you shouldn't be able to be on estrogen and progesterone. I am postmenopausal. And so I called her today to ask her, I left a message for her practice, give me a doctor that I can go to that's going to be willing to prescribe estrogen and progesterone. But so anyways, all that said, when I started having the dryness and was diagnosed with mild vaginal atrophy, which does not mean that your vagina needs to lift weights. Because when I think of atrophy, I think of
weakness.
Yeah, you had a cast on and you take it off and your muscles atrophied. No, it is where the tissue's thin because of the estrogen, the lack of estrogen or the lower estrogen. And then you do have the vaginal dryness, irritation with sex. Even sometimes just like if you ride a bike, you can get irritated. But I started using Reverie, which is a hyaluronic acid suppository that is a game changer. And I think even if I were able to get on estrogen, I would probably still use them because it is it's people that use hyaluronic acid on their face, right? It just brings moisture into your tissues. It just plumps it up. And I have to say that I used it and then because my, PA told me about it. And the next year I went back and I'm like, so how's my vaginal, atrophy? And she's like, completely gone.
So is Erin common? Is that do you think with just that, that's okay? Or do you think that there's still importance of the estrogen supplement? Because I kind of switched to where I'm just doing the Reverie now. But I'm wondering, should I be doing both?
Yeah, and it's very symptomatic and symptom dependent is what I would say. I would also say that newer data has shown if you had breast cancer, it is absolutely okay to use vaginal estrogen. And anyone who is telling you otherwise has not been updated on the guidelines changing. And I'm thrilled to hear that you do and that your clinicians are up to date on that. But there are so many breast cancer survivors who have been told you cannot ever have systemic estrogen and you cannot ever have topical localized estrogen in the vagina. And that is wrong. That's a really important piece because there are women that Reverie won't help. There are women that do really need that topical estrogen also. And so I think really making sure that patients know to push for that and that clinicians also know that those guidelines and recommendations have changed is a huge part of improving the quality of life for breast cancer survivors. So that's a huge piece of the puzzle that I'm like, we're really dropped the ball for breast cancer survivors for a long time on that by erring on this side of better safe than sorry. But I think that caused so much discomfort for so many women where we see topical estrogen is really released and absorbed locally within the vagina and the vaginal tissue when it comes to that. Reverie is exactly like you mentioned, that hyaluronic option. And I think it's a great option. So when I talk to people, I usually talk about kind of this runway of options, right? And the first option can even just be over-the-counter lubricants. A lot of people will use just lubricants during intercourse, or they have capsules that you can put up into the vaginal canal that slowly dissipate lubricant from the inside out. And so I always tell people, if you're feeling like it's drier during intercourse, to put one of those in before you go on a date night with your partner, just because then it can kind of start to have that from the inside out moisture as opposed to just outside in when you're using lubricants. So that's an important thing that we could try too. If that doesn't work, then I think Reverie is a great option. If Reverie isn't working for you, then I think the vaginal estrogen is an option. Do I think if you feel fine and you're not having any issues and intercourse isn't painful, or it doesn't feel like, I've had people say oh, it feels like the Sahara down there, or oh, it feels like sandpaper, right? If it's not feeling like that, I don't think you need to be chasing things and chasing options for management. But if it is feeling like that, then I think it's worthwhile figuring out, well, what can we do to make you more comfortable?
Yeah, I I have very painful sex, and that's what it was like sandpaper. It hurt so bad. Like it felt like knives. That's why I felt like it was sharp. And then after using, I did the estrogen suppository at first, and then I ran out. And so then instead of going to the doctor again, I just did the Reverie. But I will say that it did fix it. And then last night we got jiggy, and it hurt like a motherfucker. And it's because I have not been consistent. And you do have to stay on it. Like, it's not, I was thinking it was fixed because, like, 2 months ago, we were going strong and I wasn't putting anything else in. I was like, oh, I'm healed. But no, last night I was like, oh my God. So
Yeah.
back on it.
And that like knives that you talk about, it literally can be exactly that. So when the tissue gets soft and more atrophied, it's kind of like tissue paper. And when you like slide your hands on tissue paper, how it kind of like rips really easily? It's the same thing with friction in the vaginal canal. And so you actually end up and can get these like micro tears within the vaginal canal. And so the reason why it feels like knives is because you literally can get these like micro tears, almost like paper cuts in a way. And so it can feel really, really painful. And that's why like urination can burn too, is if you get these micro tears on the outside, then as the urine passes and hits it, it's kind of like that postpartum recovery. If you ever had, a repair after birth or any lacerations when you urinate, that acidity in the urine burns like the dickens as it comes. So really thinking about that too. And using like going back to the peri bottle usage, right? Like splashing water as you're urinating to dilute that urine so it's not burning when it comes out. So they're all like little tips and tricks and things that you can do. The goal is to obviously avoid those micro tears by using these options. But if that is something that you're like, man, this is really hurting in the day or two that follows intimacy, then that's a good way of kind of getting around those days.
Yeah, and for the listeners too, just to clarify, we do use lubricant during sex. What I'm talking. If you have not experienced what I'm experiencing,
Yeah.
you're not there yet, and I pray for you that you never are.
I don't
But
think lubricants really,
They-
they never worked for me either.
it does. It's like I don't know why it doesn't work. It just doesn't. But I
That's
will say the other products did with regular use. I guess that's the key.
That's the key. Well, I was going to say, just to go back to when you said, like, I'm glad your clinicians are open to you using vaginal estrogen. They're not. I use it. I buy it like, through
Black market, Erin?
the black market. I have somebody that comes to my house and drops it off. We have to do the handoff. They don't want me to use any. And I'm like, are you kidding me? You have estrogen receptors in almost every part of your body. I mean, I got plantar fasciitis from lack of hormones, achy joints, brain fog. I mean, you have them everywhere. And I wish I could take, estrogen and progesterone to help mitigate those symptoms. But I'm on a mission to find somebody that will actually prescribe them for me, because I've even offered to sign a waiver. I'll sign a waiver and say, I will not hold you responsible. It's like, for me, it's a quality versus quantity of life. Like, I don't, care if like maybe I'll die a little bit earlier because my breast cancer risk is, instead of 7%, it's 14%. The possibility, I'll mitigate it other ways than to live like miserable until I'm 95. So speaking of that, though, when you are working with clients or when you are working with patients who have maybe been to a physician, and I've had this happen to me, where they just try to say, well, you're just getting older. Like, it's just part of aging. What would you say to those people who have had that experience? When, I don't want to call it gaslighting. It's not medical gaslighting, but it's just,
Oh, I think it is.
it's just, it's just dismissive. Like, like I had a physician tell me that when I was gaining weight, this was during perimenopause, and he's like, well, I mean, you're getting older and your metabolism is slowing down. I'm like, I'm eating the exact same I was as 3 years ago. I'm working out exactly the same. All of my, lifestyle factors, I get good sleep, I eat very healthy, I exercise every day. I think more and more data is showing that your metabolism doesn't really start to tank until like your 60s and 70s. That coincides probably with, lack of movement. But so what would your advice be to somebody who that has had that happen when they've gone to see their healthcare provider?
Yeah, I mean, I'd really encourage you to find a different healthcare clinician then, right? Like find one that works for you. I think there are so many women who think about this as being in a relationship with your clinician, but if your clinician isn't serving you, then it's okay to break up with them. It's okay to find a new clinician that you feel like listens to you better. It's okay to find a clinician who you feel like is more up to date in perimenopause management. And I think about this a lot in terms of so much of the way that I am a clinician changed as I went through some of the things that I had been counseling my patients on, right? The way I talked about IUD insertions changed after I got an IUD. The way that I looked at pregnancy and postpartum changed after I had a kid. The way I talked about breastfeeding changed after I breastfed 3 kids. And we look at women in medicine and we look at how long and what the trajectory is. And we know there's so many more female OB-GYNs in the field now, but most of them are really like coming into their late 30s, like early 50s. Like, I don't think we have a ton of female physicians that are on the other side of menopause that really have that like validation and anger and frustration of what they experienced, then changing the way that they practice medicine. And so I do have hope that it's something that's going to improve with time as we start to have a shit ton of female physicians that then go through menopause also. And while they've been saying, hey, it's because of this, when that doesn't add up and answer their own questions and their own issues, I think we're going to see a lot larger of a movement within OB-GYN that starts to be like, actually, I think the advice we're giving patients isn't really functional. So I'm hopeful for that. But I do think it's a lot of this self-advocacy. You've got to learn what you feel is right about your body and how you talk about it. And I think a lot of that is appropriate symptom tracking. And then really paying attention to what are these things that are bothering you? What are the things that are keeping you up at night? Are they hot flashes? Are they night sweats? Is it the weight gain? Does it happen every night? Is it cyclical, right? Like really mapping these out, because the more receipts you bring with you, the harder it is to dismiss you. And so I think really sharing, this is what I'm experiencing and it's been going on for this long. No, I don't want to just watch and wait because I've been watching and waiting already. So what are my options taking account what I've been experiencing, right? And really thinking about how do I make my quality of life better? And I think that begins with advocating for yourself in clinic.
Well, I want to speak to that about being an advocate. I am the biggest advocate for myself. I want to tell you a little bit about my experience, just so you'll be shocked. When I was diagnosed with breast cancer, I live in Atlanta. They have a great hospital system that makes all the appointments for you. It's wonderful. You don't have to like call every doctor. I need to be, seen. But I saw the radiation oncologist because they have you go to like the breast care doctor, then the medical oncologist, then the radiation oncologist, And so my husband was with me and she says, okay, well, I was 44 at the time. So she says, you're considered early onset. And what we, recommend, I had already talked to the breast care surgeon, had decided I had opted for a lumpectomy rather than a full mastectomy, even though I could have qualified for one based on early onset. She's like, you'll have your lumpectomy, you'll do 33 rounds of radiation. And then when you see the medical oncologist, you'll do 10 years of tamoxifen. So I said, okay, well, tell me, like, what is the recurrence with radiation versus without? It really wasn't a big difference. And so I said, I'm not going to do radiation. I had already made up my mind before I even went there that I wasn't going to do radiation, but I was at least open to hearing what the statistics were, what the, literature said. And she's like, this is the protocol. She tells me this is the protocol. And she says, I will never agree. These are her exact words. I will never agree to you not having radiation unless your final biopsy comes back clear, and that's not going to happen. And my husband and I, we left there. He's like, you're never going back to her. And my final biopsy actually had no cancer in it, which is crazy. But I had been doing all kinds of visualization. I'm a total hippie. I was visualizing my body getting rid of the cancer cells. And I'm not advocating for anyone to like go against, what their physician recommends. But I just happen to be a good researcher. I look into all of the, I'm looking at not just like curing me of this DCIS stage 0 breast cancer. I was looking for, 20 years down the line after I've had 33 rounds of radiation, what's going to happen to my body from being exposed to that much radiation. And wouldn't you know, and you probably know this, but the protocol has completely changed around DCIS. Now they consider it more of a wait and see and track it and monitor it. They don't do this aggressive 33 rounds of radiation, 10 years of tamoxifen, which I did not do that either. My medical oncologist was completely fine with me, which is why I still see her. But it's just crazy to me that I understand that doctors, have all of this knowledge. They've gone to school for a long time. I'm like, I don't want you to treat me like a protocol. I want you to treat me as an individual. I don't fit in a box of, okay, we're just going to treat everyone the same. And so that's, I think, what the language around or in the way that patients are treated, it definitely needs to be more individualized.
Yeah, I think there's a big disconnect here because as clinicians, we talk about evidence-based medicine, and evidence-based medicine is really important, and everything we do should be based on evidence-based medicine. But evidence-based medicine essentially groups everybody together as one big cohort. And when we look at that, essentially it's kind of an L curve. So you've got the people that it's going to work for in the middle, but then you also do have outliers. And so when we treat everybody on the same protocol, you're losing those kind of like tapered edges as being different. And I think about this often with birth control. I've had so many patients, especially recently, who've come to me wanting to come off of birth control. They're having X, Y, and Z symptoms. And I think, yes, I want you to have discernment and be thoughtful in the symptoms that you have. And I don't want you to be panicky and overly throw all caution to the wind. But at the same time, if I disregard any symptom that you tell me because it's not what's consistent for the bulk of patients, then I'm not listening to your individual experience. And so I think we sacrifice anecdotal stories and experiences for greater evidence-based care, which is so critical and so important. And also we are individuals that are then participating in the system. And there unfortunately just is not a way in medicine to have nuance within that. There is no way to have a standard of care with nuance within it. And so I think that that's such an important piece, going back to what you said earlier, this idea of being like, I'll sign a waiver, right? This idea of being like, I understand you may have a clinical protocol that might be my best chance at X, Y, and Z. And that doesn't match with what my individual goals, interests, desires are, right? And so I think that there is this kind of like give and take that we can have both as clinicians and patients, is saying, I understand the value of evidence-based medicine and the evidence-based model, and it really lacks that individuality within it. So where are the points where we can flex within it without abandoning evidence-based medicine? Because that is going to be best for everyone overall, right? But the problem is what's best for everyone overall doesn't always take into account the individual experiences. And so it becomes this very complex problem of this like chicken or the egg, where it comes to what are we sacrificing? Are we sacrificing overall, numbers for everybody and recurrence rate for everybody, or are we sacrificing the individual experience? And can we get a win on all accounts? And so that's where I think it's really important to know yourself and know what feels best for you, and to be able to have that communication with your clinician where you can say, this works for me or this doesn't work for me, right? And if it doesn't work for me and I'm turning down the recommendation that you're suggesting, I am aware that that may come with different risks, right? Like, I think that's the problem, is people want everything all at once. And unfortunately, there's no way to guarantee it, right? And I think that clinicians so often are like so rigid, as in there's only one option and it has to serve everyone. And I think sometimes it just doesn't.
Yeah. I love, Erin, that you share that story. And I think it's just so inspiring to people to be your own advocate, because I am such like a whatever the doctor says type person. And I really think that that's important for women to hear, that you weren't, it was not an emotional based decision. That's the important piece I really want everyone to take away, is that she really did her own education. She is, if she is in functional health school, like has a naturally science minded brain that's going for this. So she's using her own expertise. But if you're not like that, then go to somebody in your life, hopefully, that is like that for guidance, or get a second opinion with a doctor or something like that. I love that Erin's challenged that, because in the end she was right. Her gut was right. But Nikki, you also brought up birth control, and I'm curious your thoughts on, because I couldn't believe when I went in for all of my symptoms, which I had no idea most of them were related to perimenopause. Erin was telling me for years, I'd be like, oh, my husband smells like garlic. I swear to God, he smells like garlic. And she's like, it's you. And I'm like, it is not me. And she's like, it is. And I'm like,
Hormones.
yeah. I didn't believe her. I don't know. Now I'm believing it. Wait, why do you think it's me? She's like, it is. Trust me. I can't sleep. I've got hip problems every night. I'm like waking up. She's like, it's your hormones. I'm like, it's not. It's not. This is like a leg problem. This is not hormones. Anyway, so finally, when I had my big list with all these random things on it that I thought there's no way in hell they could all be related, and took it to the doctor, the first thing she said to me was, we can put you on birth control pill, and that would be the hormones. Is that a viable option? Or is that real? Is that as good as me taking? I'm on estrogen and progesterone and testosterone. I'm on all three now, but because I refused the birth control pill. But it would have been simpler, because I've always been kind of anti-birth control pill. And I don't know why. Intuitive. I don't know. Is it intuitive? I don't know. I just felt like I was always like, I had my husband get snipped. I was like, I'm not taking that. I just didn't know, but maybe I was overthinking it all these years, and it really is really kind of good. I don't know.
I mean, it's funny, right? Because the three things that you say you're taking are estrogen, progesterone, and testosterone. And the two things that are in a birth control pill are estrogen and progesterone, right?
So see,
So
I had just taken the pill.
I mean, there's different doses, and there's different types of estrogens, and there's different types of progesterones, or there's really one main estrogen in the birth control pill, but there's several different types of progesterones. So that is the easiest option in total transparency, right? That is what clinicians are most comfortable prescribing. That is what is most frequently prescribed. But the alternative that you are choosing it really kind of is the same thing. It's just dosed differently and it's absorbed differently. And it kind of depends on what your preferences are. There are a lot of women who also do need a birth control, right? And there are a lot of women who their partner didn't get snipped. And so I think a lot of it does take all of it into the equation as well, that we can still get pregnant in our 40s. So if your partner hasn't been snipped and you don't want to be using condoms, right? And you're thinking about estrogen and progesterone and hormone replacement options, right? A birth control is a super good option, because then you're kind of like killing a ton of birds with one stone, right? But there are other options where you can do it more as a cream or as a patch, and you can dose it differently, and you can dose up and dose down. And there's so many different ways that you can do it, that there's not a one size fits all.
So maybe it is a safe option that someone should be willing to try if their doctor, if they haven't got on anything and they're having their symptoms, if a
I love
doctor
birth
suggests
control. I love
you do.
birth control.
Is there an age recommendation that someone should? I mean, I know the old, thinking was you come off of it like at 40, just because
That's what I'm thinking. I thought you weren't supposed to take it longer.
Yeah, that's outdated. It used to be come off at 35. Well, it is come off at 35 if you're a smoker. So if you smoke cigarettes, the risk of you having, a blood clot is much higher. If you have high blood pressure, it is recommended to come off, right? But if you have neither high blood pressure nor migraines with aura, nor you smoke cigarettes, right, then it is absolutely a safe option. And for most people, we'll leave them on birth control through 51 or 52 and then come off and be like, hey, are you even on the other side of menopause? So that's an option also. You don't want to keep someone on birth control through their mid to late 50s, but through 50, 51, 52 is absolutely a reasonable option.
Why not? Is it
That's a great question. I don't know. I should know that.
Well,
I don't know. I mean, that's just like, that is just kind of standard of care. And I wish I should have a better answer. I will be more prepared next time.
Well, it's just so interesting that, I think we think of hormones as almost just as decorative, like chemicals, but how important. And I mean, I think that the thinking is changing around, like, people, it used to be that when you got reached like 60 or somewhere around there, that then you would come off HRT. And now there's this thinking that you stay on estrogen, progesterone, and testosterone until you die.
Yeah. So what about if it just somebody that is on menopause or in menopause or over menopause, postmenopausal? Menopause is 1 day.
Right. Menopause is 1 day.
Okay. So they're postmenopausal, and is it too late then to start HRT?
No, it's not too late. No, it's not too late. And a lot of the thoughts and a lot of the antiquated thoughts came from kind of this, and it was the whole conversation we had within the last year of them removing that black box warning. There was a 2002 study that was called the Women's Health Initiative. That was the WHI, that used higher dose estrogens than we use now. And it did it later in life than what we do now, starting later. And there were more risks that were proven than the way we prescribe them now. And so the goal of this removal of the black box warning was more reflective of the way that we actually prescribe them now, and showing, we can do this very safely at a long duration and throughout kind of the quality of your entire duration of your life. So making that quality of life better. Yeah, you can stay on them longer than we thought. It is okay to start them at any time. It is okay to start them earlier. It is okay to start them later. Like, everything kind of got disproved from this 2002 study. And there's really no excuse for clinicians to not know this and to be saying things like, oh, you need to come off of this at 51, or you need to come off of it at 55, or you need to come off of it at 60, right? So really making sure that you're kind of advocating for that good care also.
Well, so this has always been my thought about estrogen, progesterone, is that if they cause cancer, why are you not having more breast cancer in young women when they're at their
When they're on
reproductive height?
the pill.
Right. And they're like, ovulating every 28 days and their estrogen and progesterone ideal levels. You don't see the breast cancer. I mean, I know that there are outliers. You have women in their 20s that get breast cancer, but why do we not see that more in younger women? Is it because it's natural estrogen that your body's producing, and the way that you detoxify it through your body is done a different pathway?
I'm not entirely sure, to be honest.
I just have always thought, like, why? And I do know that when I had breast cancer, it was probably even before I don't even think I was perimenopausal. I think I didn't start perimenopause until probably a few years after that, because I think I started perimenopause around 48, probably finished menopause around 52. But I definitely got estrogen dominant during perimenopause. I mean, I got ginormous boobs. I was just totally, I think, estrogen dominant, just some of the issues that I was having. I think that oftentimes, when people are going through perimenopause, they're just thinking like hot flashes and vaginal dryness, but there's so many other things. So, like, speak about some of the, like, maybe lesser, like Elizabeth saying, symptoms that we would have during perimenopause that maybe people don't expect to be related to perimenopause.
Yeah, I think the brain fog is probably the biggest one, right? The like forgetfulness and the brain fog. That one is what I hear people most often say in retrospect. Oh yeah, I've really been noticing that, right? Hot flashes is definitely what we hear most common, but the hot flashes are also night sweats as well for so many people. So that's a big one. I do think the weight gain is probably one of the most common one. Elizabeth, going back to what you had said earlier, joint pain can be a really common one. Migraines can be a common one that we can see. There's so many. The libido is a big one. Like there's so many just different things that anxiety. Oh, that's a big one. I feel like
anxiety. I developed
anxiety
that.
is a really big one.
I got allergic to everything. Like I seem to like it. Hormones were giving me a resiliency, I think, that when I was starting to have the declining hormones, that like I got allergic to my shampoo and conditioner that I had used for years. And I think it was related to perimenopause. I mean, I broke out with rashes. I had to, I always have crazy symptoms anyways. Well, and when you speak about hot flashes versus night sweats, are they basically the same thing?
Yes and no, because night sweats can also be the like cold sweats, right? So you like, it can be kind of one or both. It can be that you wake up and you're like burning hot and sweating, or it can be like cold sweats, like you wake up and you're fully drenched. Whereas hot flashes tend to be more of that kind of like spike in temperature, that character that we've seen where you're like fanning yourself and then within a minute it kind of goes away, right? So it presents a little bit differently.
So I have where I'll wake up before the hot flash, and I think it's a drop in blood sugar because it's like something wakes me up and it's not the hot flash, and then I have the hot flash. So I feel like my drop in my blood sugar precipitates the hot flash. It's like for some reason, do you know if there's a connection between that?
I don't. I haven't seen a continuous glucose
Okay.
monitoring of that to really be able to see if it would drop and kind of come back that quickly. It would be, if you're not then substituting with glucose and like eating something right away, it feels like it would be unusual that it would drop and then come right back, right? When we see like drops in glucose, then we remedy it with eating, we remedy it with juice, we remedy it with a popsicle, right? So you've got to kind of rebound that sugar. So I don't know. I don't know.
And so the other question I have is that when you do have a hot flash and you feel like you're 147 degrees inside, but your temperature doesn't change.
Yeah. Yeah. I mean, one of the most common things too is people try to fan themselves, and that actually ends up making you more hot. So try to avoid that if you
You're
can.
like, surely I'm beet red right now. Like,
And
surely-
honestly, most people are actually, because
Well,
it is
I do know
very
that I get a
visceral
little bit of
reaction.
flushing, but I'm like, I feel like, I'll feel my head to think like I have a temperature, and I do not have a temperature. But I'm like, I'm like on broil inside.
I can't believe I've never had one.
I know. You're
Lucky you. That's what I'm saying. Don't tell your friends that, right? Exactly. Lucky you. And so that's exactly it. If you were to take all if you were to take 15 of your friends and put them in a round table and ask them, what is your perimenopause experience? Everyone is going to have something totally different. And everyone is going to have different variations, different strengths of their perimenopause. And that doesn't mean that anyone's perimenopause is better or worse than somebody else's. They're just different. And so when we also look at how do we make this better, when you think about the fact that every single person is experiencing these differently, it gives you a little bit more understanding as to why there isn't such a perfect standard protocol to it also, and why nuance is really important when it comes to managing some of these symptoms or treating some of these symptoms, is that everybody does present with different things. And so how do we listen to you? How do you share what it is that's really not working for you, right? Insomnia is another one that I forgot to mention also.
Oh, that's a big one.
Yeah, insomnia is a huge one, right? So like there are so many people who have different symptoms and different things. And it's just a matter of like, okay, well, what's most problematic to you? And then you try to tackle that one, right?
Yeah. So I was going to ask if there was any trick for women to know if they're experiencing perimenopause symptoms versus a true health autoimmune disease condition or something else. But I guess probably you're going to say just compile a list of everything, bring it in, and it's going to be it could be, we could not, we don't really know. I mean, the symptoms are so wildly, like they're large, extreme, they affects everything. I think if you're
And
in
they
the
last
age
so long,
window,
right?
there's a good chance if you're in the age window, perimenopause is linked to it.
Yeah. Yeah. And that's kind of the like interesting and frustrating part of it is it's really easy to be like, oh, it's perimenopause. And so we can scapegoat perimenopause really easily too. And so I think that that's an interesting point is if it isn't improving with some of the things that you're doing, then it might be worthwhile to look into it deeper, right? Blood work is always going to be an important thing, but yeah, I think there's so many different pieces to it.
Well, talk to us about Take Back Trust.
Yeah.
What made you decide? Tell us what it is, and then kind of what led you to
Yeah. So I've been an OB-GYN PA for about a decade. And over time, I would have friends that would text me questions and say, hey, Nikki, what about this? Right? Hey, Nikki, how about this? And then I've just been kind of answering them one off, if you will. And I got very involved in reproductive healthcare and advocacy work over the last several years as it became more polarized and it became harder to access. And when it started getting a little bit worse, then I ended up leaning into it more. And so I compiled a website where you can educate and empower yourself and kind of start to pay attention to some of those things. So one of the features that we have on the website is what's called a provider visit planner, where you can start to plan for an upcoming visit. So much of what we've talked about is really learning how to advocate as a patient. And that's so much of the work that we do on Take Back Trust is really teaching people how to start noticing those things and asking for better care and asking for more engaged care. And really where that had come from too is I had one patient one time who said to me, hey, Nikki, what questions am I supposed to ask you? And I was like, oh, well, I'll answer them because I'm a pretty good clinician and I like kind of know what you should know. But most clinicians are really rushed. And if somebody asks you, hey, what questions should I ask you? You're going to say like, and walk out the door and close the visit, right? And so I think that there's so much of what we can get out of these visits is kind of prompted by what we put into these visits as well. And so really preparing in advance for a clinical visit is how we make the most out of our healthcare system right now. And I think our healthcare system is so broken on so many levels. And these visits are so fast and so rushed. So how do we make the most of that 5 to 10 minutes that you get with a clinician? And so that was really kind of the beginning of Take Back Trust for me.
I love it. So you have like a list of questions for people to bring to their provider.
Exactly.
That's great. I hope everyone takes a look at that. I know I will. That sounds wonderful because we just don't know. The layperson has no idea what to ask.
Exactly. Yeah.
Well, tell us about your book that's coming out.
Yay. So my book is called We Deserve More, and it talks about how reproductive healthcare is broken and what you can do about it. And it really walks you through kind of the background of reproductive healthcare. And so some of the things that we haven't really touched on during this conversation that I think are important to highlight are even the background of reproductive healthcare. And so you may or may not know this, but what is generally referred to as the grandfather of gynecology, Dr. Marion Sims, essentially perfected, if you will, his surgical skills on unanesthetized enslaved Black women.
I do know that.
Yep. And so there are several women who underwent up to 30 different surgeries. And then he went on to do these surgeries on anesthetized white women. And so we look at kind of this basis of very broken care and this basis of distrust and this basis where pain management was not taken seriously from women. And then we've built years and years onto this pretty broken foundation. And you have clinicians that spend so much time in their training learning about surgical emergencies, and OB-GYN by nature and by specialty is such a massive scope that they need to know that there's a lot of things that are falling through the cracks, and perimenopause management is one of them, right? Because they don't learn enough about it and they're not trained well enough on it because there's so much more other things, other content that they're learning during residency and training. And so I think we're seeing a lot of these like relational parts of care are kind of falling through the cracks, if you will. And so it talks a lot about the foundations of gynecology, and then it moves into, well, how is that showing up now? And so much of that also talks about what are we seeing on the internet? how are people doing their own research? Tell me about like the Facebook groups that people join looking for community, right? It's not all bad. There's a lot on social media that is mis and disinformation, but there's also a lot of good community that happens, right? And then what are we seeing in the media? So the way that like the Pit has shown good models of medical care, and the way that Grey's Anatomy talked about being a survivor of sexual assault, right? And so just the different ways in which we see in 2026 now how all these other compounding elements have played into reproductive health care. And then it kind of says now, based off of what you've learned, how do you take that and then learn how to advocate for yourself within clinic? So it's really bringing home the whole conversation that we've had today on listening to yourself, figuring out what the pieces are of your story that aren't working for you, and how do you get better care within the very broken medical care system that we find ourselves in right now.
Sounds like an amazing book.
It
Right.
does. It sounds like a ton of research. And so I'm sure it was challenging to write. So kudos to you. But it also sounds like really important work. And examining history is the best way for us to improve and moving forward. I know we still have gynecological exams that we are not treated with pain management for, that when they're going in, and not just a basic swab, but like
A
there's some other,
biopsy or
yeah,
something,
like biopsies and stuff that they
or
are not
something.
numbing us for, which is insane. It feels like so archaic to
Yep.
me.
Yeah, it's barbaric. And so a lot of it talks about, well, where did that come from? And then how do we advocate for better pain management? And how do we do it in a way that's actually effective, right? Because by the way, and for any listeners, if you're going in for a cervical biopsy or you're going in for an endometrial biopsy, if you've had abnormal bleeding and you're in your 40s, 50s, postmenopausal bleeding, right? You can't just like on the day of your procedure be like, oh, and by the way, I would like pain management, which you should be able to. But like, these are things we have to plan for in advance. And so really asking in the first moment, what are things that can make me more comfortable? What are things that I can do? Is it nitrous oxide? Is it laughing gas? Is it a Xanax, right? Like, that's okay to ask for. And so what are the ways that we can plan for pain management so that pain management is not an afterthought? And so I have a full chapter on asking for and getting pain management, because that's one of the biggest issues we see in gynecological care.
Yeah, I had a uterine biopsy before I had an ablation, just to check, thickness of
It
the
sucks.
lining. And I mean, it's like you go in there, you're just like, not only are they going to go into go through your cervix, go into your uterus, but also, are sitting with a speculum, cranked open basically for more than just a gynecological exam.
Yeah.
And no pain medicine. Yeah. So it definitely.
Yeah. And then they're going to tell you it's just a cramp, right?
Yeah.
They're going to tell you
Yeah.
you're going to feel a
You're going to
slight
feel
cramp.
crampy.
You're going to feel a little crampy. And so I think that's also part of the equation, is helping clinicians to understand we need to be speaking about this in different ways. We need to be talking about pain management in advance. So it's an entire systems change that we need on behalf of both clinicians and patients. And so that's really the goal of this book, is to increase that awareness so that we can improve that from all sides.
Yeah. It reminds me of the saying that Betty White has been attributed with saying, is that, how something about, like, if you want to say something about being tough, it's like tough like a vagina. We can do something. Like,
Yeah, I think she said like what? Forget
tough like balls. Because they hurt when they get kicked, like a vagina.
Yeah. So she was like,
down
there's
there.
nothing tougher than a woman's vagina. Like,
yeah. I mean, well, it just goes to show you just really how tough women are. We are just amazing. I mean, and I'm not discounting men. I have 3 sons and a husband that are all wonderful. Women, we are just, women that give birth unmedicated. I mean, we do all kinds of things unmedicated. And if it was a man, we know that, like, a man, when he goes to get a vasectomy, he gets all kinds of, special treatment. So
yeah, my husband got his vasectomy under full anesthesia that was covered by our insurance and cost us $42.
yes, that would never happen for a woman.
never happened.
Never. No. And you know what, though? I'm happy for him, because that was the best option for him.
Yes.
So I say that with my full heart and my full girth, that like, That is how it should be. Like, just because I think this concept of like women are tough has actually harmed us, because now we tell ourselves we have to be tough, when in actuality, like, can you just give me the pain management that I deserve up front so I don't have to be so goddamn tough? That would be great. Thanks. You know? So like, that's how I think it should be, is that like my husband, they asked him, do you get woozy? And he said, yes. And he got pain management. Like, great. Let's do that for everyone.
Exactly. And
Yeah.
insurance to pay for it.
And insurance to pay for it for everyone.
Yeah. So, well, we have so enjoyed talking to you. And I know that our listeners will get so much out of our conversation. Make sure that if you haven't hit the follow button on the podcast, that you do that so that you can stay in the loop whenever we release a new episode.
And you can follow us on Instagram, TikTok, and watch full versions of YouTube. And Erin will put all of Nikki's contact information in the show notes. And I, of course, will tag her whenever we post the video on social media. But we will see you next week. And I hope you guys have a great week. Thanks, Nikki, again for joining us.
Thanks for having me.
Thanks. Bye.
This has been a production of Estrogen Dropouts, LLC.